Hello, and welcome to the webinar on reversing DOACs, providing answers on why, when, and how. I'm Dr. Deborah Siegal, a hematologist in Ottawa, Canada, and I'll be joined by Dr. Geoff Barnes, who's a cardiologist in Ann Arbor, Michigan. The learning objectives of our online module today are to discuss with clinical colleagues the appropriate use of specific DOAC reversal agents, to explain the efficacy and safety of the pharmacotherapeutic options for DOAC reversal, and to advise on appropriate institutional approaches to DOAC reversal agents. This module received grant support from Alexion Pharmaceuticals. We're going to start our discussion today with a case. Harry is a 72-year-old man who uses dabigatran for stroke prevention in atrial fibrillation. He presents to the emergency department with a 3-day history of bloody stools. His past medical history is significant for hemorrhoids, hypertension, and obesity with a BMI of 32, and he takes dabigatran 150 milligrams twice daily for stroke prevention and atrial fibrillation, a lisinopril, atorvastatin, and also aspirin 100 milligrams daily. In the emergency department, he's hemodynamically stable with a heart rate of 89, a blood pressure of 134/76, and his laboratory studies show that his hemoglobin is reduced from baseline at 120 grams per liter. His creatinine is also elevated from his baseline at 168 micromoles per liter, which gives him a creatinine clearance of 62 mils per minute. So when faced with patients who are having anticoagulant-related bleeding, it's important to consider these key questions. 1, how severe is the bleed? 2, have supportive measures been initiated? 3, what oral anticoagulant or OAC has been taken and when? 4, is the oral anticoagulant present in significant quantities? 5, is there a role for reversal? 6, which reversal strategy? And then finally, when to restart oral anticoagulants after bleeding has resolved. It's also important to remember that anticoagulant-related bleeding is the main complication of oral anticoagulant therapy and affects about 2 to 4% of patients per year. Although patients will have ongoing bleeding, it's important to address oral anticoagulants because the presence of an anticoagulant will impair hemostasis and therefore make it more difficult for patients to stop bleeding. So the emergency department physician wants to know if Harry should be treated with a DOAC reversal agent. What do you need to know first? And so the key first piece of information here that's important is how severe is his bleeding event. At this point, Harry is not hemodynamically unstable. He does have clinically overt bleeding, but he has not had a 20 gram per liter drop in hemoglobin and has not received red blood cell transfusion of 2 units or more. And then finally, Harry is not bleeding into a critical organ. So if we look at this slide, it shows a framework for considering the types of bleeding that patients can present with. On the left-hand side, you see in green, non-major bleeding, and then there's a spectrum of increasing severity over towards the right-hand side of the screen. In red, you can see examples of life, limb, or organ-threatening bleeding, such as intracranial bleeding or other critical site bleeding. Patients in this category may also have hemodynamic compromise or a significant drop in hemoglobin of 20 grams per liter or more, or they require a number of red blood cell transfusion. In the orange category in the middle are examples of major bleeding that is not immediately life-threatening, as is Harry's bleeding, in that they may be hemodynamically stable with gastrointestinal or other types of bleeding, but that there is a concern about deterioration. And in fact, the blue arrow on the bottom part of the screen shows that clinical reassessment is very important as patients may deteriorate rapidly. And this is significant because the type of bleeding a patient has really just does dictate the overall approach to management. On the left-hand side of the screen, for patients with non-major bleeding, you may opt to continue oral anticoagulants and imply local measures like compression. At this point, there's an opportunity to monitor, including reviewing the indication for anticoagulation, that the dose and frequency are correct, and that other laboratory parameters like the hemoglobin or platelet count, renal or liver function, are in the normal range, and also address any co-medications that may be contributing to bleeding, like drug interactions or antiplatelet therapies or NSAIDs. As we progress down on the spectrum of severity in the orange, you can see at this point for major bleeding, anticoagulants are temporarily interrupted and additional measures are applied, including compression, perhaps volume replacement with intravenous fluids or transfusion support. It's also important here to start thinking about definitive interventions because, as we mentioned, if patients have bleeding, it's important to consider whether or not an intervention or procedure or surgery needs to be done in order to stop the bleeding. as simply removing the effect of the anticoagulant is not going to be sufficient. And then finally, you may consider other types of hemostatic strategies. And this is particularly true for patients now on the right-hand side in red, for whom we're definitely going to interrupt anticoagulants and then apply reversal or hemostatic strategies. And those agents depend on the type of anticoagulant the patient is receiving. And we'll talk about that further throughout this discussion. Additional measures such as antifibrinolytic therapy like tranexamic acid or aminocaproic acid are also possibilities, although there aren't many data supporting the use of these drugs in this setting. The next really important question to address is whether or not the DOAC is present in significant quantities. And this table shows the individual DOACs and their effect on routine coagulation tests, which are shown in the top part of the table in white. And then on the bottom part of the table in yellow, you can see specialized testing, which are DOAC specific. So if we focus on the top part of the table in white, you can see that overall, the DOACs have a minimal effect on routine coagulation tests that we're familiar with, including PT, INR, and APTT. If we look at dabigatran may prolong the PTT, but this is quite dependent on the assay that is used at an individual site and is not reliable for detecting the levels of dabigatran. On the contrary, thrombin time is extremely sensitive to even small amounts of dabigatran and can actually be quite helpful. If the thrombin time is prolonged, that means that some amount of dabigatran is present, but if the thrombin time is normal, then that's reassuring that there is no dabigatran present. With rivaroxaban, similarly, it may prolong the PT or INR, but this is also quite dependent on the type of assay which is used to measure those tests. And you can see that apixaban and edoxaban do not reliably change any of those coagulation assays. So what we're really looking at is the bottom 3 rows, which include the dilute thrombin time and eccrine clotting time, which are specific assays for dabigatran, and anti-factor Xa assays, which are specific assays for the factor Xa inhibitors. And these are more accurate and reliable for measuring DOAC levels, although they are not readily available. So what do we do without the help of laboratory testing, and how do we interpret the results of tests that are conducted? So the routine coagulation tests like PT or INR and APTT can be used qualitatively. So this means that they are helpful for ruling in clinically significant levels of DOACs, but they may not be sensitive enough to rule out an anticoagulant effect. So we need to interpret the results of these tests in the context of the patient. And this may include which local assays are used and how well that local assay performs with the drug. And many people don't have access to that type of information. So the next really key steps are to determine the dosing interval of the drug and when the patient last took their dose, to understand the drug pharmacokinetics, which includes the half-life, and then finally to evaluate renal function and liver function. And I put here, especially for dabigatran, because it is the most renally excreted of all of the DOACs. However, they are all renally and hepatically cleared to some degree. So those metabolic abnormalities can certainly influence the level of drug that's circulating. And then finally, if specific DOAC assays are available, they can be helpful because they're more reliable, but they're not routinely available at all sites. And sometimes there's a delay in accessing the results of these tests. So if we continue on Harry's course, he last took his dose of dabigatran about 6 hours ago. And that's important because, as you know, the DOACs have a quick onset, which means that they're therapeutic within 2 to 3 hours of ingestion. And so Harry is close to his peak at this point. And with his worsening renal function, we are concerned that there will be a prolonged presence of dabigatran in his system. His routine coagulation test showed a normal PT, INR, and a slightly prolonged PTT, which is in keeping with the characteristics that I talked about earlier. The presence of dabigatran can prolong the PTT in some assays. So dabigatran has been held, and gastroenterology has been consulted for consideration of endoscopy and definitive intervention. He's receiving intravenous fluids, and then 4 hours later, his vital signs are updated as shown. His heart rate is now 110, and his blood pressure has dropped to 106 on 62. A repeat hemoglobin is now 102. Remember, his previous was 120, and his baseline was 134, and he's had continued bleeding without bowel movements. So the team is quite concerned. There are 2 agents that definitively reverse DOAC anticoagulant effect, idarucizumab and andexanet alpha. Idarucizumab is a humanized monoclonal antibody fragment that targets dabigatran, and it's indicated for urgent surgeries or procedures or life-threatening or uncontrolled bleeding in dabigatran-treated patients, and it's administered in a dose of 5 grams intravenously. Andexanet alpha on the right-hand side of the table is a human recombinant factor 10A variant, and it's indicated for the reversal of apixaban or rivaroxaban for life-threatening or uncontrolled bleeding. And the dosing of andexanet alpha is dependent on the type of factor 10A inhibitor the patient has taken and also the timing of their last dose. The REVERSE-AD study was the registration study of idarucizumab for the reversal of dabigatran. As you can see in this slide, patients who were treated with dabigatran and had either uncontrolled bleeding or required emergency surgery were treated with idarucizumab 5 grams intravenously. In these patients, hemostasis was achieved in 68% of patients within 24 hours, and the median time to hemostasis in bleeding patients without intracranial hemorrhage was 2.5 hours. You can see in the graphs on the bottom of this screen, on the left, we show with the red arrow that after the administration of idarucizumab, there was a dramatic reduction in the concentration of unbound dabigatran, which is the active form of the drug. And also in the right panel, you can see that after administration of idarucizumab, the prolonged APTT was corrected. In this study, there were patients with GI bleeding, and the cohort of GI bleeding patients was published separately as a sub-analysis. You can see that a total of 134 patients were treated in REVERSE-AD for a gastrointestinal bleeding, and the time to cessation of bleeding within 24 hours was 2.6 hours. It's important to recognize here that these patients who've had bleeding have a prothrombotic condition at baseline. Their anticoagulants have now been withdrawn, and they've been given reversal agents in addition to the activation of their coagulation systems in order to stop bleeding. And so these patients are at risk for thrombotic events. And you can see that thrombotic events occurred in about 5% of patients in the bleeding group. Importantly, these patients are also multimorbid and elderly, and the mortality associated with GI bleeding on dabigatran in these patients who received idarucizumab was 11% at 30 days, which just indicates that gastrointestinal bleeding is not benign, and these patients are at risk of severe outcomes. So Harry was given idarucizumab 5 grams intravenously as per protocol. He was transfused with 2 units of red blood cells, and he underwent endoscopy. His bleeding resolved and his hemoglobin stabilized after the procedure. Activated PCC has been proposed by expert consensus guidance based on limited in vitro data. However, if idarucizumab is available, it should be preferred. So the next important question in Harry's journey is when anticoagulation should be restarted for his atrial fibrillation. As we discussed previously, Harry is at risk for stroke and systemic embolism because of his atrial fibrillation, and now his anticoagulants have been withdrawn, his anticoagulant effect has been reversed, his coagulation system is activated, and he's admitted to hospital with an acute medical illness. All of these things increase the risk of him having thrombosis in the short term. In this meta-analysis of 12 observational studies, anticoagulants were discontinued for 90 days or longer in about 42% of patients after anticoagulant-related GI bleeding. The risk of recurrent bleeding was 2-fold higher in patients who restarted anticoagulants compared to those who did not, but the risk of thromboembolism was 70% lower. It's important to keep in mind that because these were observational studies, patients were not randomly assigned to treatment, and therefore there were likely baseline differences between the patient groups that contributed to these results. In this cohort study of patients who were hospitalized for anticoagulant-related bleeding, there were similar results. Among patients who resumed anticoagulants after bleeding, there was an increased risk of rebleeding, but a reduced risk of thrombosis and death. And these results are consistent with other more recent observational data, which supports that anticoagulation can reduce the risk of thrombosis after gastrointestinal bleeding, but that this comes at a cost of an increased risk of bleeding. So in summary, Harry's case identifies 4 important learning points to take away. The key first step in assessing patients who have anticoagulant-related bleeding is to assess the bleeding severity, and this includes attention to hemodynamics, transfusion, and the location of bleeding in order to direct interventional or surgical treatments to stop bleeding if necessary. Bleeding severity should be reassessed, and the patient response to local treatment and other treatments should be reevaluated. Idarucizumab is indicated for dabigatran-related major bleeding, which is associated with poor outcomes at 30 days in this population, including a 10% risk of mortality. And then finally, Reinitiation of anticoagulation after GI bleeding should be considered, although the timing and dosing strategy is uncertain because there are no high-quality data to inform this at present. And now it's my pleasure to hand over to Dr. Barnes for the remainder of the discussion.
Well, I'm Geoffrey Barnes from the University of Michigan. I'm going to take over here, and we're going to start with case number 2. This is a case of a gentleman, Glenn. Glenn is an 86-year-old man who's being assessed in the emergency department because of somnolence, right-sided weakness, and decreased sensation that was noted by his retirement home staff. He undergoes a CT head scan, which shows an acute hemorrhage in his basal ganglia. Now, he has a medical history of atrial fibrillation, hypertension, a transient ischemic attack, and coronary disease with a drug-eluting stent placed in 2009. His current medications include apixaban, ramipril, atorvastatin, and low-dose aspirin. On physical examination, his vital signs show a tachycardia with a heart rate of 115. He's mildly hypertensive with a blood pressure of 145/92, and his Glasgow coma score is 13. Important laboratory studies include a hemoglobin of 137 grams per liter, platelets of 258, his INR is 1.1, and his PTT is 32 seconds, and his creatinine is 78 micromoles per liter. So we're going to come back to these 7 key questions that we need to ask ourselves whenever we're managing somebody with a bleed associated with oral anticoagulant use. First, how severe is the bleed? Secondly, what supportive measures have been initiated? Third, which oral anticoagulant has been taken and when was it last taken? Fourth, is oral anticoagulant present in any significant quantities? Fifth, is there a role for reversal? Sixth, which reversal strategy should we use? And then finally, seventh, when should we restart the anticoagulant? Now, you've seen this structure before, but let's think about this with regards to Glenn's case. Glenn has had an intracranial hemorrhage, so that puts him in not just the major bleeding category, but really the life, limb, or organ-threatening category on the far right of the screen. So this is somebody who's really one of the most severe presentations of a bleeding event. So how do we think about management? Well, of course, we start on the left with our local measures, our supportive measures. We step up from there into the orange group. And because this is a life, limb, or organ-threatening bleed, we're going to start to initiate some of these red strategies, our reversal or hemostatic strategies. So for a patient like Glenn, who's been using a factor Xa inhibitor, this is where we're going to think about some of our specific reversal agents. So for any patient who presents with an intracranial hemorrhage, we have our ABCs of acute hemorrhage stabilization. First, we have A, assess alertness. If the alertness is decreased, that might be because there was mass effect, and therefore we need to initiate hyperosmolar therapy. B, we need to optimize blood pressure. We need to quickly bring the blood pressure down somewhere in the range of a systolic blood pressure between 120 and 160 millimeters of mercury. And then C, we need to correct the coagulopathy. If the patient is taking an anticoagulant, which Glenn is, we need to reverse it using our fastest and most effective available agent. So the question really here is to treat or not to treat. And that's what the emergency room doctor calls and wants to know. Should we be treating this patient with one of the direct oral anticoagulant or DOAC reversal agents? So what's the first question we're going to go to? Well, of course, we're going to ask ourselves, is there any significant anticoagulant present for this patient? Now, of course, we may not have access to a rapidly available lab test, but we do know things about the half-life of the drugs. As you look at this chart, I want you to focus on the bottom line. That's the line we've bolded. Notice how 12 hours is a pretty good estimate for the half-life, really for any of the direct oral anticoagulants, dabigatran, rivaroxaban, apixaban, and edoxaban. So we can think about patients who are within 12 to 24 hours likely have significant quantities of anticoagulant in their system. And that's certainly the case for our patient. It's also important because if we choose to give a reversal agent, In this case, we can see data from the Annexa-4 study with andexanet alpha. We need to understand how much anticoagulant may be present in the system so we know how long to treat them for. In this case, you can see in the black line, these were patients who were receiving placebo, but were on an anti-10A inhibitor. And if they did not receive any reversal agent, they had this slow decline in their anti-factor 10A activity, as shown in the black line, such that by about 12 hours after the placebo was given, they have a significant reduction. Now, I want you to contrast that with the red line. In this case, the specific reversal agent, andexanet alpha, was given. Look how rapidly the anti-10A activity drops, really even at the time the bolus completes. And by continuing that infusion for 2 hours, we're able to maintain a very low anti-factor 10A activity level. But as soon as you stop the infusion of andexanet alpha, you can see the anti-factor 10A activity starts to creep back up. And those red boxes and the red line starts to come up at the 3 and 4 hour mark, such that about 5 hours after the end of the bolus, we've basically gotten back to where we would have been if there had been placebo given. So the length of the infusion of andexanet alpha really determines the length of time you have to stop and address whatever is causing this bleeding concern. So for Glenn, as we come back, we look at his medications, we find out that he last took his medications about 6 hours ago. So he's definitely in that window where we need to think that he has significant presence of anticoagulant on board. And because of the severity of his intracranial hemorrhage, we probably need to be aggressive in treating him. Well, I think the right answer here is to give somebody andexanet alpha. Andexanet alpha is our specific reversal agent for patients who are taking factor 10A inhibitors. It's actually a human recombinant factor 10A variant, and it has competitive binding with the anti-10A inhibitors such as apixaban and rivaroxaban. And so its indication is for the reversal of either apixaban or rivaroxaban in the setting of a life-threatening or uncontrolled bleeding event. Now, the dosing is dependent on a couple factors. First, you have to know which anticoagulant they are taking. And then secondly, you need to know the time since the last dose of the anticoagulant was administered. Now, this is currently licensed in many countries, including the United States, United Kingdom, and the European Union. And there's also an ongoing randomized trial for intracranial hemorrhage being led out of the United Kingdom. Now, some of the data from the Annexa-4 study show that if we look at this anti-factor 10A activity level at baseline, you can see the average was right around 200 nanograms per milliliter. But after this bolus was given, you give it in a bolus followed by an infusion, that anti-10A activity level rapidly dropped almost to undetectable levels and stayed there throughout the duration of the infusion. But once the infusion stopped, that anti-factor 10A activity level did come up. And we saw this in another graphical format on a prior slide. Now, these were patients who all had major bleeding events within 18 hours after receiving a factor 10A inhibitor, such as apixaban, rivaroxaban, and a few with edoxaban. The good news is the vast majority of these patients, 82%, achieved good or excellent hemostasis within 12 hours. Let's look at some of the adverse events associated with this particular study. So in the reverse AD study, that was the study looking at idarucizumab. They had the two different groups. They had the emergent reversal for surgery and the bleeding group, whereas Annexa-4 was simply a group of bleeding patients on the far right. If we look at the thrombotic events, that's that first row there. 30-day event rates in the reverse AD study were about 5%, in Annexa-4 were about 10%. If you look at the death, the overall death at 30 days, that's sort of the next highlighted row. You see about 13% in the reverse AD groups, 14% in the Annexa-4 study. So again, we're seeing some similar numbers here, but certainly some concern that these patients are at high risk for adverse events. It's also important to note how often patients restarted their antithrombotic agents. And you can see from the Annexa-4 study, about 62% restarted any antithrombotic agent, but a small minority, only 28%, actually restarted their oral anticoagulant. This is something we're going to get at here in a few minutes. The question now is, what would you recommend if andexanet alpha was not available at your institution? We know that it's not available at every hospital and in every country. What's your backup option? Well, I think the answer here is we're probably going to administer a standard prothrombin complex concentrate. Now, we've summarized here 3 reasonably sized observational data reports that have looked at the use of PCCs for factor Xa inhibitor related bleeding. You can see we have a total of a little over 200 patients across these 3 studies. These were all cohort studies with prospective enrollment that used chart review and an institutional protocol. And they had some variation in how the 4-factor PCC on the first 2 or the activated PCC on the right were administered, but all of them were given roughly 12 or so hours after the patient had taken their last dose. What you can see here is that the hemostasis assessment ranged anywhere between 50 and 85%, so similar or lower than what we saw in the Annexa-4 study, that the thromboembolism rates were actually quite low, ranging from 4 to 8%. However, the risk of death was really quite high, anywhere from 14 to 32%. Again, highlighting that these are often very sick patients, even when we're being aggressive with their management. Now, it's important to understand the limitations of that data, especially the data looking at PCCs for the management of factor Xa related bleeding. All of these were single-arm observational studies, so they lacked a comparator group. And so it's really hard to understand exactly how that differs between our treatment group of PCCs and any other control or comparator group when it comes to some important outcomes like hemostatic efficacy, thrombotic events, and even mortality. Well, what guidance or guidelines do we have from various bodies? So the first is the Anticoagulation Forum has provided us some guidance back in 2019, and they suggest administering a reversal agent only if bleeding is life-threatening, into a critical organ, or not controlled with maximal supportive measures. And there's reasonable expectation that the patient has clinically relevant plasma DOAC levels. Now, they're not saying you have to run a blood test to prove it, but if you know they've taken the drug within a reasonable amount of time, let's say within the last 12 to 24 hours, and they have this life-threatening bleeding, that would be a reasonable time to give a reversal agent. And specifically, they state if the patient has a rivaroxaban or apixaban associated major bleed in which reversal is warranted, then they would suggest the use of andexanet alpha. But if andexanet alpha is not available, then they would suggest the use of a 4-factor PCC. Now, the National Institute for Health and Care Excellence in the UK also has some guidance out. Theirs came just earlier in 2021, back in May, and they say that andexanet alpha is recommended as an option for reversing anticoagulation from either an apixaban or rivaroxaban associated life-threatening or uncontrolled bleed only if the bleed is gastrointestinal in nature and the company provides andexanet alpha according to the commercial arrangement. They also state that there is an ongoing study looking at the use of andexanet alpha for patients with intracranial hemorrhage, but there's some question about the level of efficacy and the cost effectiveness from the UK perspective. And that's why they didn't give the full endorsement for intracranial hemorrhage related bleeding from a factor Xa inhibitor. So let's step back to our case of Glenn. Again, he presented after taking apixaban. He's got an acute intracranial hemorrhage. So what things do we need to do? We assess his alertness, we optimize his blood pressure, and now we need to correct his coagulopathy. So for him, we're going to give the low dose of andexanet alpha. That's a 400 milligram IV bolus, followed by a 4 milligram per minute infusion over 120 minutes. That's a total of 480 milligrams IV infusion. After we've managed his acute bleed, we need to ask ourselves, is it appropriate to restart his anticoagulant? And if so, when? And it's important to remember that one size does not fit all when it comes to restarting anticoagulants after a life-threatening or major bleed. So here's a nice flow chart that you can work through. The first thing to ask yourself is, has the bleeding stopped? Obviously, if the bleeding has not stopped, then we should not be restarting the anticoagulant. We need to continue providing supportive therapies, identify the source, perhaps get support from our procedural or surgical colleagues, think about other approaches to reversal or hemostasis, and address any contributory comorbidities and medications. However, once the bleeding has stopped, now is a great opportunity to reassess. Does this patient still have an ongoing indication for oral anticoagulants? Sometimes the answer to that is no, in which case let's stop their anticoagulant and not put them at risk for bleeding in the future. However, frequently there is still an ongoing indication. Maybe the patient still has atrial fibrillation, or maybe they've still had a recent venous thromboembolic event and they're at risk for recurrence. So you need to try and assess what's their thromboembolic risk versus what's their bleeding risk, and think about which is more significant at a given time. It's always important to take that information to the patient and or the patient's family and health caregivers and have a shared decision-making discussion, because it's important to understand that the patient needs to be a part of the decision to either resume or discontinue their oral anticoagulant. Now, if you make the decision to resume, you need to make sure you check some baseline labs, review those medications, and if they're on other medications that put them at risk for bleeding, perhaps we can deprescribe those. Let's make sure they're on the right drug and dose for their oral anticoagulant, provide them with plenty of education and counseling, and make sure we arrange for follow-up so we can continually reassess their risk of thrombosis and bleeding, and perhaps have to readdress this decision about continuation or discontinuation of anticoagulants in the future. So in summary, this is a case of Glenn. He had an intracranial hemorrhage on a factor Xa inhibitor. It was important that we assessed his bleeding severity, recognizing this as a life-threatening bleed. We ensured that supportive measures and monitoring were initiated. We also said that his oral anticoagulant intake was recent, so the likelihood of clinically significant factor Xa inhibitor was high. And therefore, we said we're going to go ahead and reverse his anticoagulant with the use of andexanet alpha if it was available at our center. Otherwise, we could provide some hemostatic therapy, such as the use of a prothrombin complex concentrate if andexanet alpha was not available. And finally, we had a very comprehensive and thoughtful approach to when and whether we should restart his anticoagulant after his bleeding was controlled. I want to transition now to a third case. This is a case of Lillie. Lillie is an 83-year-old woman who presents to the emergency department after having a fall in her bathroom. Her x-rays showed that she has a left hip fracture, and she really is going to require some urgent surgical repair of that fracture. Now, she tells you that she uses rivaroxaban because of a history of atrial fibrillation, and her last pill of rivaroxaban was taken about 24 hours ago. Now, the orthopedic surgery team is asking, is it safe to take her to surgery? Is there any need to check an anti-factor Xa level? And should they be using some sort of a reversal agent to help manage her case? Well, I want you to remember that when we think about the reversal agents for anticoagulants, they're really limited, especially for andexanet alpha, only to patients with life-threatening or uncontrolled bleeding. Andexanet alpha has not been tested and is not approved for reversal of anticoagulant use prior to urgent or emergent surgery. So that would not be an appropriate use in this situation. Rather, I would recommend you think about a recent study called the PAUSE study. This was a study published in 2019 that looked at a standard approach to holding oral anticoagulants prior to surgical procedures. Now, in this case, these were all elective surgeries, but I think we can infer some important information from this study that can help us with the case of Lillie. If you look here, they had this standard protocol where they looked at which direct oral anticoagulant a patient was used. In the case of dabigatran, they also looked at renal function. And then third, they asked, what kind of surgical associated bleeding risk are we to expect? So let's look at those bottom two lines. That's the patient on rivaroxaban, which is what Lillie was taking. If this patient had a high surgical bleeding risk procedure, something like a major surgery, maybe a hip surgery, then they would recommend holding rivaroxaban for 2 days prior to the day of surgery. If it were a lower risk bleeding procedure, you'd only need to hold it for 1 day. So in this case, I think we can recommend to the team, she's already gone 24 hours since she last took her oral anticoagulant. If we could wait an additional 24 hours, that would give us 48 hours of time without any oral anticoagulant, and we may be able to proceed with surgery without any need to reverse the direct oral anticoagulant. However, to be safe, it would probably be best to avoid any neuraxial anesthesia and use more of a general anesthesia approach in this case. Now, let's say they go forward with surgery. One of the questions that we always get asked is, should the anticoagulant be restarted after surgery? And if so, when should that happen? Well, thankfully, the PAUSE study also gave us some guidance there, and they had this nice setup for when to resume the anticoagulant. Importantly, they recommended that for patients undergoing high bleeding risk procedures, it's okay to wait maybe even 2 or 3 days after surgery before restarting the anticoagulant. Because remember, once you take that direct oral anticoagulant, your patient is fully anticoagulated within just a handful of hours. So in this case, a patient who's using rivaroxaban and undergoing a high surgical bleeding risk procedure, that's the second from the bottom line, this would be somebody who could restart their anticoagulant maybe on post-op day 2 or even post-op day 3. So we would recommend that if the surgery here is elective and it's not emergent to proceed, delay 24 to 48 hours so that we can get plenty of clearance of her direct oral anticoagulant. If it's emergent, then you might need to think about using a different agent. So in this case, we would probably use a prothrombin complex concentrate because she was taking a factor Xa inhibitor. But if the patient had been on dabigatran, you could use idarucizumab in that case. And furthermore, we would definitely recommend all centers have a protocol for how they manage direct oral anticoagulants before emergent surgical procedures so that we can make sure that all patients get evidence-based, consistent care. So I want to summarize the talk that we've had today in this learning session. Remember to always come back to 7 key questions anytime you're managing an oral anticoagulant-related bleeding event. You need to ask yourself, how severe is the bleed? What supportive measures have been initiated? What anticoagulant was the patient taking, and when was the last time they took it? And based on that information, do you believe that there's any significant quantity of that anticoagulant present in their system? Based on that, you can ask yourself, is there a role for reversal? And if so, which reversal strategy should be used? And of course, after you've managed their acute bleeding event, when should you restart their oral anticoagulant? We hope this has been a helpful discussion today, and we wish you the best of luck. Thank you.